Good evening, colleagues, or good night, rather. Can someone confirm that you're hearing me?
Good night. Good night. Yes, hearing you.
Okay. Are
Hi, Dr. Akin. Good evening.
Good evening. Good evening.
Duladel here. Sorry, I didn't realize that you had joined. So I'm just giving the official welcome.
Okay.
So you have a.
Yeah, go ahead, Duladel. Go ahead.
Oh, okay. Yes. So you have a class full of ladies this year, and you have two groups: the postgraduate diploma in geriatric medicine and the postgraduate diploma in gerontology. About 3 different countries represented. Ladies, Professor Aiken is a consultant urologist at the University Hospital of the West Indies, and he has been giving talks similar to this in our program for a few years, and we're grateful. We know he has a busy schedule, so we're happy that he's here tonight, and we know that you will learn a lot. Enjoy. I will be hopping off shortly, but I do wish for you a good class. Thanks again, Dr. Aiken.
You're welcome, Duladel. Thank you. Good evening, colleagues. So we're going to be looking at the effect of aging on genitourinary tract function. Sorry to be late. I had an emergency call that I had to deal with, and so I apologize for the late start. We have a lot of ground to cover. So let me just get into the meat of the matter. Why isn't my slide advancing now? Oh boy. Slide is not advancing.
Could you just click on it? Click on the screen where you're at and then try to advance again.
Okay, that works. Let me see. Okay. All right, so the objectives for this evening is that at the end of this lecture, participants should be able to discuss the effects of aging on kidney function as well as lower urinary tract function. No conflicts of interest to declare. All right, so aging, I certainly am not an expert on aging, and so these are just some general comments I would like to make based on my own research on aging generally. It's a complex and poorly understood process, and it may be related to our underlying genetic deck of cards we have been dealt, or environmental influences we have experienced, and of course, it may be due to chance occurrences. Aging proceeds at variable rates in different people, and it is fundamentally thought to be due to cellular degeneration, otherwise known as senescence, and faulty repair mechanisms. As you know, as we get older, our repair mechanisms do not function as well as in younger persons. It certainly is an inevitable consequence in all species. And it is felt that biological systems have built-in reserves that allow for adequate function over the lifespan of the organism in spite of external stressors, and this is known as compensation. Decompensation or failure occurs if biological reserve collapses due to excessive stress or if compensatory mechanisms induce dysfunction. So sometimes compensatory mechanisms may overcompensate, and for example, you may have excessive inflammation taking place that in and of itself causes degeneration of tissues. There's what is known as the redundancy model of aging, where systems are described as blocks. And these blocks do not age per se, but fail for varied reasons over time. Aging effect occurs when the redundancy of these blocks is exhausted. And the rate of failure of blocks within a system varies and depends on the number of remaining blocks, some of which are critical for survival. So when those critical blocks for survival are lost, then death may ensue. So having made those general comments on aging, and as I said, I'm certainly not an expert on aging, we're going to look at something that is closer home, and that is aging, the effect of aging on kidney function. We know that the aging kidney, the glomerular filtration rate and the renal plasma flow decreases with age, beginning at around the age of 30. The decline in glomerular filtration rate with age occurs in healthy, normotensive persons. So it is not a disease process. It is a normal process of aging. The GFR diminishes with advancing age. And this reduction is in GFR is about 0.7 to 0.9 mils per minute per year between the ages of 30 to 75 years. So approximately 1 mil per minute per year between the ages of 30 to 75. If a person has comorbidities, and especially if those comorbidities are poorly managed, such as hypertension, diabetes mellitus, and if they have obstructive uropathy from whatever cause, such as BPH, then the rate of decline may be increased with the presence of these comorbidities. We know also that after the age of 75, the rate of decline increases, but in a healthy, normotensive person, this is not enough to cause kidney failure in the normal lifespan. So kidney failure should not occur in the normal lifespan of a person with normal aging and the effects of normal aging on the kidney. When you examine the kidneys, we know that as age advances, the cortical volume declines with age, while the medullary volume increases with aging. Nephrosclerosis is something that occurs as the kidney ages, and it occurs in both a focal and non-segmental or global way. The glomeruli become sclerosed or replaced with collagen or fibrous tissue. And there's also interstitial fibrosis and tubular atrophy. And of course, in the blood vessels themselves, in the arterioles, you have arterial sclerosis. And this leads to a decline in glomerular filtration rate by 0.63 mils per minute per 1.73 meters squared per year in healthy aging adults. And this decline is due to a slowly progressive loss of nephrons, as we said, beginning at age 30. So consistently, these changes have been found to start at age 30. As nephrons are lost, there's compensatory hypertrophy of residual non-sclerotic glomeruli, as well as their attached tubules, and this is called nephron hypertrophy. So if you look at the effects of these on the kidney function, you have the glomerular sclerosis taking place where the glomeruli are replaced by collagen tissue. At the same time, you're having mesangial expansion, so the mesangium in the interstices between the arterioles and the glomeruli increases. And this, the overall effect of this is hypofiltration taking place from the glomeruli. At the same time, in the interstices and tubules of the kidney, you have tubular atrophy taking place. You have increased fibrosis in your interstitium, leading to interstitial fibrosis. Functionally, there is reduced sodium reabsorption and reduced potassium secretion. The medulla, there is not the sort of hypertonicity that occurs in the medulla, leading to conservation of fluid is decreased. So you have medulla hypotonicity. And in addition, tubular atrophy and tubular fat degeneration takes place. And in some tubules, you'll notice divertically appearing. So these are the tubular interstitial changes that take place. And then finally, the vascular changes that take place in both the large vessels and the small vessels. So of course you have renal atherosclerosis taking place in the renal arteries. There is arterial subendothelial hyalinosis, and this leads to aglomerular circulation, as well as persons age, there is thought to be vascular dysautonomia, so that the regulatory mechanisms that lead to arterial vasoconstriction and dilation does not occur. And this leads to, all of these leads to the vulnerability of the kidney to the effects of aging, as these different changes takes place in the renal vasculature, the interstitials of the kidney, and the glomeruli. So what you find taking place is that, as we mentioned, there's an age-related decline in glomerular filtration rate due to all the changes that we just saw earlier. But this is in contradistinction to the development of chronic kidney disease. We know that proximal tubular function is maintained in the healthy age. So although there may be a decline in sodium reabsorption and potassium secretion, we know that function is nevertheless maintained. We know that erythropoietin secretion from the kidneys are maintained, and the hemoglobin concentration are maintained in the healthy age. And we know that serum urea levels are normal. We know also that the fractional excretion of calcium, magnesium, and phosphorus are normal in the healthy aged population. In terms of potassium, the fractional excretion of potassium is relatively diminished in relation to the glomerular filtration rate due to a low serum aldosterone level and aldosterone resistance, which takes place in the healthy aged. And if you look at the urinalysis, they have neither albuminuria or hematuria. So in the healthy aged, although GFR is declining, there are none of the features of chronic kidney disease seen in the healthy aged. Renal reserve capacity is also, sorry, 1 second, a call just came in. Sorry, so the renal reserve is the capacity of the kidney to increase basal glomerular filtration rate by at least 20% after an adequate stimulus, such as a protein load. And again, we see that in the healthy aged, the renal reserve is preserved, but the magnitude of this reserve diminishes with age. So how do we estimate the glomerular filtration rate in the elderly? There is what is known as a Cockcroft-Gault equation, which we don't expect you to memorize, but it's one of the equations that we use to estimate the GFR. And the caveat here is that the person cannot have a creatinine that is in flux. It has to be a stable creatinine. And we're going to look at this formula shortly. Then there's a modification of diet in renal disease, MDRD formula. The Cockcroft-Gault underestimates creatinine clearance in very old people. And part of the reason why it does that is you'll recall that as people age, they lose muscle mass, and muscle mass is where the creatinine comes from. So, and the Cockcroft-Gault equation uses the serum creatinine to estimate the GFR. So it's not surprising that in older persons with diminished muscle mass, that the Cockcroft-Gault equation may underestimate the creatinine clearance. The MDRD formula does not require the patient's weight for calculating GFR, and that's an advantage. And the next line tells you what I just mentioned. Beware of the effect of senile lean mass reduction due to sarcopenia. There is a Keller formula, which is very simple. It's the simplest of all the formulae to diagnose GFR, and that's 130 minus the age. So for example, if you have a 60-year-old man, then 130 minus 60 would give you the GFR, which is 70. In old persons or in aged persons with a GFR less than 60 mils per minute, the cystatin E GFR is not superior to the GFR calculated using the Cockcroft-Gault or MDRD formulas. The cystatin E GFR is used in some labs to calculate the glomerular filtration rate, but it's not superior to the other two less cumbersome formulae. So this slide shows all the various formulae that we just spoke about. The Cockcroft-Gault is 140 minus the age times the weight in kilograms divided by 72 times the serum creatinine. And in females, they multiply by 0.85. As you can see, the MDRD formula is very, very laborious looking, and nobody expects you to walk around with these formulae in your head. These are things that you would look up and use to calculate the creatinine clearance. And it's particularly important when you giving medication that is renally excreted. You may have to correct for the creatinine clearance, and so these formulae assume importance when prescribing drugs that are particularly renally excreted or metabolized. All right, so we're going to leave aging and kidney function and look at aging and lower urinary tract function. But before doing so, let me pause and take any questions that you might have on aging and upper urinary tract function. Are there any questions related to what we spoke about earlier? All right, so if there are no questions, let's move on because we have a lot of ground to cover. So the prevalence of lower urinary tract symptoms increases with age in both sexes. And this is something that's very important to understand. Years ago, we used to use the term prostatism in men until enterprising urologists at a health fair gave out what is known as the International Prostate Symptom Score, which is a questionnaire measuring lower urinary tract symptoms to men and age-matched women. And lo and behold, the women had the same high prevalence of lower urinary tract symptoms as the men did. Now, women don't have a prostate. And so the term prostatism went out of vogue because we now recognize that those lower urinary tract symptoms are not necessarily related to the presence of a prostate, but are in fact related to changes in bladder function and other aspects of lower urinary tract function that change with age. The precise etiology of this increase in the frequency of lower urinary tract symptoms is not known. We're not sure if biological age is the main independent variable, or whether it's the accumulation of conditions or agents that accrue at different rates in different individuals related to inflammatory states and tissue ischemia. For example, we know that persons who have the metabolic syndrome or who have excessive abdominal girth due to visceral adipose tissue, they have a higher incidence of lower urinary tract symptoms, and it may well be related to pelvic ischemia and other changes in lower urinary tract function related to systemic inflammation. We know that both the bladder as well as the outlet, the external urethral sphincter, are affected, and nocturia is a chief symptom of lower urinary tract dysfunction, and it's more prevalent with aging. We know that as persons age, there is blunting of the diurnal changes in vasopressin or ADH production. And we also now know that arterial blood pressure generally increases, which may lead to changes in the renal production of fluid. We also know that changes taking place in the midbrain and brainstem, which we're going to touch on earlier, may also lead to changes in lower urinary tract function. We know that the midbrain or the pontine micturition center is a control center for the lower urinary tract, and so changes that take place in the pontine micturition center with aging may affect lower urinary tract function. And then there are emotional and psychosocial changes that may accompany aging. And then there's what is known as white matter hyalinization, which is increased replacement of gray matter with white matter as persons age. There's a term known as inflammagen, which is an upregulation of inflammatory response with advance in age due to the cumulative lifetime exposures to antigenic loads from clinical and subclinical infections plus non-infective antigens. And this inflammagen is thought to cause excessive inflammation. And could it be this excessive inflammation that results in irreversible cellular and molecular subclinical damage that accumulates over several decades that leads to changes in the bladder architecture and blood flow that leads to this, increased in lower urinary tract symptoms? We mentioned the possibility of gradually accumulating ischemia in the lower urinary tract, and or changes in neural control due to ischemia of the nerve fibers. We know for a fact that atherosclerosis increases with aging, and this may lead to pelvic arterial insufficiency, and this can lead to detrusor overactivity and sometimes eventually detrusor underactivity. Impaired blood vessel function is characterized by endothelial dysfunction, and we know that nitric oxide deficiency is caused by oxidative stress and chronic low-grade inflammation, and we see this in persons who have increased visceral adipose tissue, as I mentioned earlier, persons with centripetal obesity have this excessive or pro-inflammatory state. And this pro-inflammatory state causes reduction in nitric oxide synthesis and secretion by your blood vessels. And this leads to endothelial dysfunction and reduction in arterial vasodilation. Bladder ischemia and bladder wall hypoxia may lead to oxidative stress and increased muscarinic receptor activity. These are all theories, plus ultrastructural damage and degeneration of the neuronal endings. And these have all been theorized as possibly causing your lower urinary tract overactivity or underactivity as persons age. Now, nocturia is one of the most frequent symptoms in aging persons, and it is defined as getting up one or more times at night to pass urine. It must be preceded, but not necessarily be followed by sleep. So if somebody is up during the night or if they have insomnia and they go to the bathroom, that's not counted as an episode of nocturia. They must be awakened by the desire or need to pass urine for it to be counted as a nocturia episode. The causes are either a reduction in functional bladder capacity, and this may be due to the overactive bladder, or it may be due to polyuric states. The reduction in functional bladder capacity might be due to an overactive bladder, either related or unrelated to aging. It may be due to bladder outlet obstruction, due to BPH, for example. One of the effects of the obstructed bladder is to become overactive, what is known as secondary detrusor overactivity. And of course, as people age, their bladder may not empty well, and they may have increased risk for lower urinary tract infections, which may cause nocturia episodes. Then there's global polyuric states, and the causes of this include polydipsia, uncontrolled diabetes mellitus, diabetes insipidus, may include hypercalcemia, lithium toxicity, and there are drugs, especially non-steroidal anti-inflammatory drugs, which may cause a global polyuric state. In addition, there is nocturnal polyuric states due to congestive cardiac failure. So persons, as they retain fluid during the days, when they become recumbent at night, the fluid is mobilized and they're the kidneys mobilizes fluid, so they have nocturnal polyuria. Persons with peripheral venous disease may also have nocturnal polyuria. Persons with ascites, obstructive sleep apnea is a well-known cause of nocturnal polyuria, because with obstructive sleep apnea, you have right heart strain, and a more atrial natriuretic factor is produced in persons with obstructive sleep apnea, which leads to a diuresis. And then, as we mentioned earlier, there may be alteration in the diurnal ADH secretion in the elderly. So these are all the causes of nocturia. As persons age, they may also develop urinary incontinence. Urinary incontinence is defined by the International Continence Society as a complaint of any involuntary loss of urine. It may be transient or it may be established. Recognized causes or types rather of urinary incontinence include stress urinary incontinence, which is the involuntary loss of urine on effort or physical exertion. Urge urinary incontinence is the involuntary loss of urine associated with urgency. Mixed urinary incontinence is when you have both. If you have overflow incontinence, that's when you have urinary retention and intermittent leaks from the bladder. And then you have continuous or true incontinence, which is due to a continuous leak of urine from the urinary tract, such as occurs in a vesical vaginal fistula. Bedwetting or nocturnal enuresis is also considered a type of urinary incontinence. And then we see reflexogenic incontinence that occurs in paraplegics. So when you stimulate their lower limb or their lower abdomen, they reflexly pass urine. There is what is known as coital incontinence. In some women, they have urinary incontinence during coitus or at orgasm. And then very importantly, in the elderly, you may have functional incontinence, which is due to restricted mobility or cognitive impairment and or structural barriers to toileting, right? So that's functional incontinence. So they're not truly incontinent, but because of the restricted mobility or cognitive impairment or barriers to them toileting, they wet themselves. In terms of the epidemiology and impact of urinary incontinence, in approximately 11% of men 60 to 64 years, some degree of urinary incontinence is seen. In community dwelling men over 85 years of age, up to 31% of men suffer from urinary incontinence. And when you look at institutionalized persons, anywhere from 10 to 84% of them suffer from some degree of urinary incontinence. On average, 50% of institutionalized persons have urinary incontinence. And in terms of women, almost 50% of women report any urinary incontinence. And 50% of these have stress urinary incontinence. So stress urinary incontinence is the most common type of urinary incontinence in women. And obviously this is related to obstetric birth trauma, and women who have repeated or multiple pregnancies may suffer disproportionately from stress urinary incontinence. In the United States, the costs associated with urinary incontinence exceed $26 billion annually. And also you have to look at the personal, social, and financial costs, which include embarrassment, social isolation, depression, and anxiety. Now, in terms of the aged, transient or sudden onset of urinary incontinence is of paramount importance. So although we defined the different types of incontinence earlier, in the aged, transient or sudden onset of urinary incontinence is particularly important. And in terms of remembering the causes of transient urinary incontinence in the elderly, we use the mnemonic DIAPPERS, D-I-A-P-P-E-R-S. D stands for delirium or confusional states related to cognitive impairment. I stands for infections, urinary tract infections. A stands for atrophic urethritis/vaginitis. 4, the first P stands for pharmaceuticals, and there are many different drugs, especially drugs that have anticholinergic side effects that may cause urinary retention and overflow incontinence that might cause sudden onset of urinary incontinence in the elderly. And remember, in the elderly, polypharmacy is the order of the day. A lot of elderly patients are on so many drugs. Then there are psychogenic causes of urinary incontinence. And then the E stands for excessive urine production. And we saw earlier things like uncontrolled diabetes, mellitus, polydipsia, hypercalcemia may all cause global or nocturnal polyuric states. In terms of functional incontinence, restricted mobility, the last R stands for restricted mobility, and urinary retention. With retention, of course, you have overflow incontinence, and with restricted mobility, you have functional incontinence. And then the S at the end stands for stool impaction or severe constipation. So these are the common causes of sudden onset of urinary incontinence in the elderly. When you see an aged person with sudden onset of urinary incontinence, typically one or more of these factors is at play. Frequently stool impaction, very common cause of urinary incontinence. Pharmaceuticals, another very common cause, and of course, acute urinary tract infections, very common cause of transient incontinence in the elderly. So what are the risk factors for urinary incontinence in the elderly? The aging bladder, of course, is one. Cognitive impairment or dementia. They may void inappropriately when it's not socially appropriate to do so because of the cognitive impairment. the restricted mobility due to rheumatoid arthritis or osteoarthritis, unable to pull a zipper quickly enough, or the restricted mobility to move to the bathroom quickly enough may, especially in someone with an overactive bladder, may cause urinary incontinence. And then there are environmental or structural barriers. You know, frequently in elderly persons, especially if the room is not well lit at night, they may not be able to find the bathroom easily or not move quickly enough because of the way their environment is set up, may not be conducive to them toileting easily. Then there may be underlying neurologic disease, things like Parkinson's disease or increased frequency or prevalence in the elderly, and that might restrict their mobility and their their ease of accessing the bathroom. And then there are other factors, comorbidities such as diabetes mellitus, which is more common in older persons, especially if it's not well controlled, leading to polyuric states, other endocrine disorders as well. Chronic cough may predispose to stress urinary incontinence, recurrent urinary tract infections. Polypharmacy, which we mentioned earlier, may have adverse effects on lower urinary tract function, especially those drugs that have anticholinergic effects. And of course, fecal impaction may lead to urinary retention and overflow incontinence. These conditions, such as Parkinson's disease, stroke, heart failure, diabetes, sleep apnea, severe constipation, frailty, and UTI, these are very common conditions in the elderly and are associated with urinary incontinence. In men specifically, the prevalence of BPH increases with age. So in men in their 50s and 60s, the prevalence is approximately 50%. By the time men reach the age of 80, 100% of men will have histological BPH. And of course, prostate cancer also increases in prevalence as men age. And these may cause obstructive uropathy and urinary retention with overflow incontinence. The treatment itself of prostate cancer may cause urinary incontinence. Urinary incontinence is a well-known complication of radical prostatectomy. External beam radiation may cause, during the treatment, may cause urgency and urgent continence, and you may have late effects on lower urinary tract and bladder function that may cause a restricted capacity and incontinence. Trauma, especially lower urinary tract trauma or trauma to the nervous system, may result in urinary incontinence. And then underlying neurologic disease such as Parkinson's disease, spinal cord injuries, CVA, all of these may increase the risk of urinary incontinence in men. In women, multiparity and obstetric trauma causes pelvic floor dysfunction, urethral hypermobility, intrinsic sphincter deficiency, and pelvic organ prolapse. All of these are related to multiparity and obstetric trauma. And of course, hypoestrogenism may exacerbate these underlying problems, especially as women reach the age of menopause. So in terms of the underlying pathophysiologic mechanisms, essentially you may have a failure to store urine. And if you think of it, the failure to store urine may be either be due to an overactive bladder or an incompetent outlet. The overactive bladder in turn may be due to uninhibited detrusor contractions, and these may be idiopathic and age-related. for example, we have what is known as detrusor hyperreflexia with impaired contractility, or DHIC. And this is a age-related finding. So the detrusor becomes overactive, but the contractions themselves are not enough to empty the bladder. So at the same time that the person is having urgency and urgent continence from an overactive detrusor, at the same time they are retaining urine in the bladder because the contractions are not enough to empty the bladder. So apart from idiopathic, you may have these bladder overactivity due to underlying neurologic disease, CVA or stroke, Parkinson's disease, multiple sclerosis, spinal cord disorders, dementia, including Alzheimer's and vascular dementia, are all associated with an overactive bladder. And then finally, you may have decreased bladder compliance, which is really dangerous because when the compliance of the bladder reduces, the pressures in the bladder increase with filling. And if the pressures in the bladder increase with filling, then the kidneys, the pressure gradient from the kidneys will be abolished, and the normal antegrade flow of urine won't take place as easily, and you'll end up with hydronephrosis and renal impairment. So decreased bladder compliance is a real issue that might lead to renal impairment. In terms of failure to store, the other main cause is an incompetent outlet. And this is mostly seen in women, intrinsic sphincter deficiency, or urethral hypermobility, or pelvic floor dysfunction. When this occurs in men, it's usually on a background of either having had previous surgery, like bladder outlet surgery as occurs during a TURP, or they have had a radical prostatectomy, or they may have an underlying neurologic disorder, or they may have suffered trauma. But men do not naturally develop pelvic floor dysfunction unless they have had one of those antecedents. In terms of failure to empty, remember that failure to empty leading to urinary retention may lead to overflow incontinence. And so if you have an underactive detrusor, which may again be due to aging or underlying neurologic disease, or things like uncontrolled diabetes leading to diabetic autonomic neuropathy, or drugs that impair detrusor contractility, all of these may lead to an underactive detrusor, leading to urinary retention and overflow incontinence. On the other hand, you may have bladder outlet obstruction leading to urinary retention, and there are many causes. The most common would include BPH, fecal impaction, prostatitis with swelling of the prostate due to edema, as well as spasm of your external sphincter, meatal stenosis that may occur in some men, especially diabetics, phimosis, we see that very commonly in diabetics, prostate cancer, pelvic organ prolapse in women, and underlying neurologic disease may all cause bladder outlet obstruction. And as we said, this may lead to overflow urinary incontinence and nocturnal enuresis or bedwetting. Overflow incontinence occurs in 7 to 11% of older people with urinary incontinence. So up to 11% of cases of urinary incontinence in older persons is due to overflow incontinence. So when we look at the aging bladder, it may be due to detrusor overactivity with normal contractility. So in those persons, they still empty their bladder, but it's just that they have an overactive bladder manifested by urgency, plus or minus urgent continence, urinary frequency, and nocturia. Or they may have detrusor hyperactivity with impaired contractility. So these patients experience urgency, urgent incontinence, but they are unable to empty the bladder during voiding. And then you may have those persons with occult neurologic compromise associated with aging, and this may contribute significantly to geriatric incontinence. We mentioned earlier the white matter changes that are occurring in the midbrain that may affect the pontine micturition center, and these may be associated with geriatric incontinence. All right, what about functional urinary incontinence now? So urinary incontinence not only requires a functionally normal lower urinary tract and pelvic floor, but it also requires sufficient cognition to sense a full bladder and interpret the desire to void. It requires sufficient cognition to locate a toilet. So in persons who have dementia, they may not be able to sense a full bladder. They may not be able to interpret the desire to void. They may not be able to locate a toilet, and they may void inappropriately. It also requires adequate mobility and manual dexterity to allow safe and efficient walking to the toilet plus unclothing. So if there is restricted mobility or restricted manual dexterity, which commonly occurs in the elderly due to frailty or arthritis, then all of these may lead to functional urinary incontinence. And then we mentioned an appropriate environment to facilitate efficient toileting. So very commonly in the elderly, you may have to have a commode right beside the bed. You can't afford for these patients to be walking to the toilet, especially in the night. Many hip fractures occur at nighttime in patients with nocturia, elderly patients with nocturia and urgency, because in the dark, they're trying to make their way to the bathroom quickly and they fall down, and falls in the elderly associated with hip fractures. These have a very, very high mortality rate. Okay, so the inability or unwillingness to access toilet facilities in time may be due to deficits of cognition, delirium, and dementia. And when you look at these, it may be due to a loss of mental awareness of the sensation of bladder fullness, a loss of ability to recognize a toilet, loss of understanding of the process of undoing clothing to void, or it may just be personal unwillingness to go to the toilet. You may have a patient who has dementia and they're just stubbornly not willing to go to the toilet. And then we mentioned, of course, the restricted mobility and restricted manual dexterity and the environmental or structural barriers to toileting. So how do you evaluate these patients and treat them? It's often difficult in the frail elderly. The evaluation should be tailored to the patient's specific issues and functional status. And you need to very commonly involve caregivers. The caregivers are a very important source of information. The evaluation includes at a minimum a medical history, a physical examination, and a urinalysis. Adjuncts, if the patients are cognitively able to do it, include a bladder diary. You may want to measure the post-void residual urine. That's the volume of urine left behind in the bladder after voiding. Urine flow rate sometimes is necessary to measure. Ultrasound and cystoscopy. Certainly a cystoscopy is not part of the routine evaluation and would only be necessary if the person has blood in the urine on urinalysis. Ultrasound may be useful for determining post-void residual urine volume and prostate size, and so on. So in terms of the medical history, we want to look at the onset and duration of the urinary incontinence, the frequency, and the amount of leakage. When does it occur? Is it a transient, acute transient thing, or is it a chronic and established urinary incontinence? If it's transient and acute, then use them mnemonic diapers and look for a functional cause of urinary incontinence. Always remember that in the elderly, these patients are usually on multiple drugs, and one of the drugs may be the offending factor, especially your drugs with anticholinergic side effects that may cause urinary retention. Also look for comorbidities, especially uncontrolled diabetes, congestive cardiac failure, and use of diuretics. Of course, an obstetric history and gynecologic history, as well as past surgical history, may shed some light on the reason for the incontinence. In terms of the medical history, also need to take into account the basic activities of daily living. These include self-care tasks, such as bathing, showering, toileting, dressing, eating, and walking. Is the patient able to do these without assistance? Is the urinary incontinence affecting their ability to do these things? You also have to look at what are called the instrumental activities of daily living, such as housekeeping, taking their medicines, using the telephone, managing money, and shopping. These are part of the overall assessment of the aged patient and how it may impact on the treatment of their urinary incontinence. And of course, you have to look at the overall impact of the urinary incontinence on the patient. So the offending medications include anticholinergics, such as your tricyclic antidepressants, antihistamines that have anticholinergic side effects, drugs that are used to treat an overactive bladder, anti-Parkinsonian drugs, antipsychotics, and skeletal muscle relaxants. All of these may cause acute onset of urinary incontinence. Other offending drugs include opiates, diuretics, alpha agonists, such as in over-the-counter cold medicines. These may cause bladder outlet obstruction by causing your external sphincter to fail to relax. Your alpha blockers, on the other hand, may cause urinary incontinence by decreasing the resistance to your bladder outlet. Sedatives and hypnotics are other agents that may cause urinary incontinence. Angiotensin converting enzyme inhibitors are associated with urinary incontinence. Calcium channel blockers, and we mentioned the non-steroidal anti-inflammatory drugs. These are medications that may be associated with nocturia and urinary incontinence. In terms of the physical examination in both men and women, you need to assess the degree of frailty. You need to do a general examination, assess their ability to ambulate, look for the neurologic deficits. And importantly, in terms of the examination of the genitourinary system, you need to specifically look to see whether they have a distended bladder, which would suggest the presence of overflow urinary incontinence. In men, always examine the external genitalia and do a digital rectal examination. You want to look for things such as meatal stenosis and phimosis. And of course, you want to do a rectal exam to assess the sphincter tone, as well as to assess the prostate size and consistency. Focused neurologic exam is always important. And you can do this simply by asking the patient, when you do your rectal examination, to contract their anal sphincter. If they are able to do that, then you know that S2, S3, S4 are intact. If their anal sphincter tone is present or increased, then you need to evaluate that as well. And in persons who may have a catheter in, the bulbocavernosus reflex can be assessed by just tugging on the catheter to see if there is reflex contraction of your anal sphincter. So these are methods of assessing your S2, S3, S4 segments, or what is known as your sacral micturition center. In women, you should examine the patient supine and standing if possible. Check for stress urinary incontinence. Ask the patient to cough or sneeze. Well, you can't ask them to sneeze, ask them to cough. Check for pelvic organ prolapse. This is why it's important to examine them standing as well. If pelvic organ prolapse is present, it's important to reduce it with your fingers and ask the patient to cough again. Many times when you reduce the pelvic organ prolapse and the patients cough, you may find that they also have stress urinary incontinence. You need to check for pelvic floor muscle function by asking the patients to squeeze your fingers when you're doing your transvaginal examination to assess the strength of their pelvic floor muscles. And of course, you need to assess S2, S3, S4 by doing your focused neurologic exam. And that's simply done by asking the patients to contract on your fingers. If they can do that, then S2, S3, S4 is intact. A urinalysis and a urine microscopy should always be done. You're looking for the presence of blood, which is 3 or more red blood cells per hypofield. There's an error on that slide. It should be 3 or more, not greater than 3. So 3 or more is considered abnormal. Looking for the presence of glucose, a positive nitrite that might suggest the presence of a UTI, a positive leukocyte esterase. And of course, if the urinalysis suggests a urinary tract infection, then it should be followed by a urine culture and sensitivity. If there is hematuria, then this should prompt referral for urinary tract imaging, at the very least an ultrasound, an abdominal, pelvic, or renal tract ultrasound should be done, and referral to a urologist would be recommended. And that's the time where a cystoscopy is indicated if there is hematuria. So how do we treat geriatric urinary incontinence? Of course, it depends on the underlying etiology of the urinary incontinence. And as we have seen, this is often multifactorial. You need not only to focus on the urinary tract, but you need to look at factors external to the urinary tract, such as the presence of polypharmacy, whether they have stool impaction, whether they have uncontrolled diabetes, for example, or they have dementia. All of these are things that are external to the urinary tract, which impact urinary tract function. Treatment, therefore, needs to be individualized and tailored depending on the specific factors that are thought to be at play. Treat the whole patient, taking into account associated diseases and disability and their level of dependency on caregivers and their degree of frailty. Look at current drug use and amend current drug use if you think there are any offending drugs. You also need to take into account the patient's life expectancy, because obviously you're not going to do anything that is invasive or that will alter in any significant way their quality of life if their life expectancy is very short. Look at also the preferences for care by the patient and their family. Of course, the cost of treatment is always something to factor in, and the goals of care may be different in different persons. So in some patients, it may just be to make them comfortable, and it may simply be wearing an adult disposable brief or diaper. In another patient who may not be as frail and who has a longer life expectancy and conditions that are reversible, then the goals of care may be different. So always treat reversible causes of transient urinary incontinence, identify and treat acute confusional state, identify and treat urinary tract infections and other infections that might cause acute urinary incontinence. In terms of atrophic vaginitis and urethritis, topical estrogen is recommended for that. If you find an offending pharmaceutical agent, then remove it or modify it. Screen for and aggressively treat depression. Identify polyuric states and treat them. So things like uncontrolled diabetes, you need to treat that. Improve mobility, manual dexterity, and remove barriers. So where mobility can be improved or where manual dexterity can be improved, then that should be done. Or sometimes it might be altering the environment. Instead of the patient going to the bathroom, bring the bathroom to the patient. In other words, put a commode beside the bed or have a urinal in the bed between the patient's legs that they can so that they can use when needed. If the patient has fecal impaction, obviously disimpaction needs to be done. A manual disimpaction or with the aid of an enema needs to be done. Always relieve pain where possible. So in patients with severe osteoarthritis, relieve the pain of the arthritic pain. Improve mobility through providing equipment that can be used to facilitate mobility. So they may need a walker or a cane. And of course, as I mentioned earlier, modify the environment. Give the patient a urinal or put a commode in the bedroom. In terms of behavioral modification, which should be the first line of treatment, there are toileting programs which include scheduled or prompted voiding. If caffeine is thought to be an offending agent, then you may need to remove that. And fluid management, there may need to be restricted fluids. There may need to be lifestyle adjustments such as decreasing weight, stopping smoking, improving bowel habits. Pelvic floor muscle training may be necessary in terms of treating stress urinary incontinence, or referral to a pelvic floor physiotherapist may be needed, or you may teach a patient to do Kegel's exercises. Stress and urge reduction strategies such as doing a Kegel's contraction or doing breathing exercises when the urge, a sudden onset of urgency occurs. There are nocturia reduction strategies such as restricting fluid intake before bedtime, passing the urine before going to bed, making sure the room is warm and not cold. These are all strategies to reduce the frequency of nocturia. Constipation management is important in those patients who suffer from constipation that may be impacting the lower urinary tract. And of course, structural modification might be necessary. In terms of specifically treating the overactive bladder, behavioral modification is important, avoiding caffeinated beverages, avoiding known bladder irritants such as spicy and peppery food, avoiding concentrated urine, emptying the bladder before going outside or going on any outing, timed voiding, and bladder training are all methods of behavioral modification. We mentioned pelvic floor muscle therapy. Specifically, you may want to prescribe antimuscarinic drugs such as tolterodine, trade name Ditrucitol, oxybutynin. Darifenacin is not available locally. So what is available locally are tolterodine or Ditrucitol and oxybutynin. Detrol, these are locally available. Side effects include dry mouth, blurred vision, constipation, and in the elderly, confusion may occur because these cross the blood-brain barrier and may affect cognition. These drugs are absolutely contraindicated in closed-angle glaucoma. So if the patient has a history of closed-angle glaucoma, you cannot prescribe these antimuscarinic agents. Selective beta-3 agonists, such as mirabegron, are available and do not have the antimuscarinic side effects. They are available not locally, unfortunately, and they are very expensive. But when available, these drugs are very useful in treating the overactive bladder without causing the antimuscarinic side effects. And if those don't work, then intravesical botulinum toxin is something the urologist can do to prevent the overactive bladder. In terms of stress urinary incontinence, pelvic floor muscle therapy is the first line of treatment, simply doing Kegel's exercises. There's a drug called duloxetine that may be used for mild stress urinary incontinence in women. And what this does, it increases the tone in the external sphincter. Age should never be a contraindication to surgery. So if conservative measures such as pelvic floor muscle therapy does not work, then you may want to consider mid-urethral slings, which have a 55% long-term success rate in the elderly. Periurethral bulking agents are also used. And as a last resort, in someone with severe stress urinary incontinence, you may consider putting in an artificial urinary sphincter. When do you refer to a urologist? If there are recurrent urinary tract infections, if there has been prior pelvic surgery or trauma or radiotherapy causing the urinary incontinence, definitely if there is hematuria, if there are high post-void residual urine volumes indicative of urinary retention, if you have new onset neurologic symptoms, then referral to both a neurologist and a urologist might be necessary. If there is persistent pelvic pain, pain should never be ignored. If there is persistent pelvic pain, then referral is recommended. If there is grade 3 pelvic organ prolapse or symptomatic pelvic organ prolapse, referral is necessary. And of course, if you have an enlarged prostate with urinary retention, referral is recommended. All right, these are the references. And that's the end of the lecture. If I was a bit rushed, I apologize. I know we needed to cover the material in a shorter time because we started late. But I'm sure you may have some questions for me. So at this time, I'll take questions if there are any.
Good night, very informative. I just want to say, since the medication have so much side effect and stuff, you think it worth giving a senior, older adults medication?
Sorry, you're breaking up. Could you repeat the
No,
question?
I say, with all the medication complications you mentioned, you think it's worth giving the senior, older adults the medication versus just probably use the depends?
So a lot of times the medications that are prescribed for a specific reason. For example, a patient may be suffering from depression and they may be prescribed antidepressants that have anticholinergic side effects, for example. So in prescribing the antidepressant, the patient may then end up with urinary retention. And that urinary retention may then lead to overflow incontinence. Or another example, the patient may have severe osteoarthritis, and they're prescribed a non-steroidal anti-inflammatory drug. But then the non-steroidal anti-inflammatory drug then causes them to have nocturnal polyuria, and they start ending up having getting up at night or having nocturia. So these drugs are usually prescribed in good faith to treat a specific problem, but the side effects may impact the lower urinary tract. So in the elderly, where multiple comorbidities may exist, patients are often on many different drugs, and some of these drugs may adversely affect lower urinary tract function, leading to either urinary retention or urinary retention with overflow incontinence. And so this is where this is the context in which we mentioned the many the various drugs that these patients are on that may cause urinary incontinence. So whenever a patient, an elderly patient, comes in, especially with new onset urinary incontinence, we mentioned that you need to take a careful inventory to see what drugs they're on, to see if there are any offending agents, and modify or remove them if possible. I hope that answers the question.
Yes, and how you feel about catheterizing them
No, catheterizing
instead of the drugs?
catheterization should never be done for urinary incontinence. It should never be done. You're going to now put a foreign body in the bladder that creates a portal for urinary tract infections. You're going to increase the risk of recurrent urinary tract infections. You're going to increase the risk of stone formation in the bladder. You're going to increase the risk in female patients of having destruction of the urethra. So a urinary catheter should never be placed for urinary incontinence. We don't recommend it.
Thank you, because that is usually be the easy way out. And thank you, sir.
You're welcome. You're
But it's
welcome.
okay for retention though.
Absolutely. So,
Okay, because we usually I have a patient that usually has urinary retention, but we'll do the in and out catheter at least once per week.
right. So in the situation where the patient is in retention of urine, then if the patient is able, if it is due to some permanent impairment of bladder contractility, then if possible, intermittent catheterization would be preferred. If it's not possible and the patient needs a long-term indwelling catheter, then a suprapubic catheter is preferred to a transurethral catheter. So in a situation where a patient has, for example, detrusor, impaired detrusor contractility, and this is thought to be permanent. For example, a patient who has long-standing diabetic autonomic neuropathy and the nerves to the bladder are just gone, then a patient like that, if they would need to be catheterized, but they're going to require a long-term catheter. And in a situation like that, they should be referred to the urologist, and a suprapubic catheter should be placed rather than having a transurethral catheter, which is going to increase the risk of infections as well as destroy the urinary urethral submucosal tuft. Any further questions? Okay, well, I know we have seven persons online. Well, thank you for staying to the very end, and I apologize again for the late start. I'm going to your coordinator asked me to share these slides with you, so I'm going to do that. I'm going to email these slides to Ms. Falloon so that you have the lecture available for future reference. All right, so if there are no
Thank
further,
you.
Thank you.
you're
Good night.
welcome. All right, so have a good night.
Good night.
All right, take care.